Kia ora and greetings. I'm Anna Mackey and I'm presenting on behalf of my team from Starship Child Health and other organisations in Auckland, New Zealand. This is on the outcome from an equity review of the cerebral palsy diagnostic process in the New Zealand setting between Māori, our Indigenous population, and non-Māori children. It was funded by the Starship Foundation. The study was triggered by the Novak paper of 2017 and corresponding work by Professor Rosalind Boyd at the University of Queensland, where there was a call for a shift in practice around early CP diagnosis. With the availability of better assessment tools and an improved understanding of family needs and wishes, means that a clinical diagnosis can now be made earlier. In New Zealand, we had no information on the diagnostic process that was happening in practice or any standardised guidelines in place. Underlying this was a very well-known health inequities for Māori people across most health conditions. So prior to establishing any guidelines around CP diagnosis, we needed to review our current practice, particularly with an equity lens, as it may be that we perpetuate further inequities when installing new practice without looking at it first. So we reviewed our New Zealand Cerebral Palsy Registry participants and included all children who were born and given a diagnosis of cerebral palsy in New Zealand over a 10-year period. We extracted data from 277 participants from the North Island 8 regions of New Zealand. The key variables that we looked at included demographics, ethnicity, and the deprivation index. This deprivation index is specific to New Zealand and derived from a census variables that reflect deprivation across geographical regions. It includes information on housing, social benefits, education, transport, and support to determine a quintile number from 1 to 5, with quintiles 1 and 2 being the least deprived geographical regions and quintiles 4 and 5 the most deprived. We also looked at birth history and clinical factors that were related to the CP diagnostic process. Analysis was completed by comparing the Māori cohort to a combined non-Māori ethnicity cohort. So we had 30% or 83 individuals who self-identified as Māori. 89% of our total cohort was from a city health region. The key finding was in our deprivation index, with a significantly higher proportion of Māori children and families living in the most deprived regions of New Zealand, quintiles 4 and 5, compared to non-Māori children. As expected, the timing of the cerebral palsy injury or insult was predominantly in the pre-perinatal period, where 90% of our cohort fitted in this group, and 10 to 11% were under the post-neonatal causes. We did find a higher proportion of Māori children in post-neonatal causes, but the numbers were too small to evaluate this further at this stage. The following slides are on the pre-perinatal diagnostic pathways. For birth history variables of gestational age, birth weight, and time spent in NICU or special care unit, we found no significant differences between Māori and non-Māori children. The following tables here are taken of the combined results and are similar profiles to those from population registries around the world. Although we had 65% of our children who were reported as spending time in the NICU or SCBU unit, and as highlighted before, no differences between our two populations. The initial description of cerebral palsy is taken from when it is first described in the medical records. Again, we found no difference between our Māori children and our non-Māori children in the timing of receiving this diagnosis, with around 40% receiving it in the first 12 months. And on average, children had a diagnosis by 19 months of age. We note we do have a lag compared to the Australian register results at 12 months of age. Functional mobility, as classified by the Gross Motor Function Classification System, found over 65% had independent mobility, and this was for both Māori and non-Māori children, with no significant differences across any of the GMFCS distributions. The profile wheel here shows the distribution for the total cohort. For both Māori and non-Māori children, spasticity was the predominant movement type with a bilateral distribution, with hemiplegia making the largest individual grouping of 38%. The gross motor function classification system was impacted the time of diagnosis description, with more severe functional impairments of GMFCS5 having an earlier diagnosis compared to those of GMFCS level 1 with a more mild presenting function. There were no significant differences between Māori and non-Māori children. Similarly, in comorbidities, there are no differences between our two cohorts. We did note approximately 40% of our cohort who have or have had epilepsy documented, and this is slightly higher than that's reported in other population registries. This was our first look at the CP diagnostic descriptors in New Zealand by ethnicity, and even now, a few years on in 2022, we're actually in a much better position with our registry data to now start looking at our complete data set, which we will be doing. However, for this small cohort, we found evidence of higher social deprivation for Māori, which is similar to New Zealand Society findings, unfortunately. There was no difference, however, in the clinical descriptors around diagnosis. However, we do know from other conditions that these socio-economic determinants of health impact very poorly on health outcomes. And there is emerging evidence now for CP in New Zealand on poorer hip health and also respiratory health for Māori children with CP. And this is being presented at this conference. The take-home messages are around continuation of collection of high quality information on Indigenous populations if we are to monitor this going forward. We also need to ensure our CP registers have targeted means of ascertainment to ensure Indigenous populations are represented. We took a lot of guidance and would recommend the implementing of the RACP position statement guidelines on the Indigenous child health, which came out in 2020. Thank you for your time today.